Yes.
Thank you very much for joining our panel session on holistic therapy and COVID reflections and opportunities ahead. As some of you will know, we started this APPG in 2018 to celebrate the huge social and economic contribution that beauty, aesthetics and the wellbeing industry makes to the economy of the UK. Now, alongside our campaigning for the industry throughout COVID, our inquiry into non-surgical cosmetics procedures, our APPG is also holding a series of panel events to bring together industry experts with parliamentarians to celebrate the industry and to discuss a range of issues that are particularly crucial for the industry at the moment. So in this session, we'll be hearing about the crucial work that holistic therapists have provided during COVID-19, supporting healthcare professionals and local communities during an extremely challenging time. So in this session, we'd like to reflect back on the pandemic to highlight the work that holistic therapists have performed, and we'd also like to look forwards to see the role that holistic therapists can play in tackling emerging problems such as long COVID, burnout, depression and PTSD. So we'll be hearing from this session from Michael Dixon, Chair of College of Medicine for Integrated Health, Karen Young, Editor and Communications Manager, FHT, Gwen Featonby, Education Lead at the NHS Natural Health School, Farah Idris, Complementary Therapist and Social Prescribing Link Worker, and Peter Makareth.
Yeah, that's fine.
Honorary Lecturer and Researcher at the Christie NHS Trust and Volunteer Complementary Therapies. So thank you to all the speakers taking part today. And I'd just like to state that we will be recording this session and it'll be made available online shortly afterwards. I'll let you all introduce yourselves. If you can introduce yourselves and give us a brief outline of your work for about 5 minutes, and then we'll open it up to questions from people. So on this session, there's myself, Judith Cummins, who's the co-chair of the group. Caroline Harris is unfortunately away on other parliamentary business, and she's the other co-chair. And we've also got the treasurer of the group, our esteemed colleague and friend Peter Dowd here from Liverpool. Hello, Peter. So if I can ask Dr. Michael Dixon, if we can start with you, please.
Well, thanks, Judith. I'm a family doctor GP in Devon in what we call an integrated centre for health, but it's an NHS facility. And I also chair the College of Medicine, which has been going for 10 years and has a commitment to medicine beyond pills and procedures. And the reason for that is simply because we're not managing to reduce the incidence of long-term disease. We've got problems with increasing opiate abuse and antibiotic resistance, and we've got to start looking outside the box in terms of what we offer our patients. And what we do offer our patients, both in the college and also down in Clumpton, where I live, is what we call the best of both. That's to say, an integrated system that brings together complementary therapy and also conventional therapy. We have several gardens, herb gardens and fruit and vegetable gardens. We have things like question time evenings when patients come with a subject like back pain or diabetes, and we have a pharmacist, a complementary therapist and a doctor who provide some of the answers, but actually most of the answers come from the patients themselves, and they often form their own groups and therefore start informing each other as to what they can do to improve their health and well-being. I think holistic therapy offers three things. It offers, on one level, simply a substitute. Somebody with back pain can go to see an osteopath or a masseur and get that treated, and therefore it's not an expense on NHS, and it's an extension of what we're able to offer. But I think there are two other areas which we need to really look at in this. One is the holistic nature of the therapies given, which involves often more time than I'm able to give as a GP, but often provides a more holistic answer. That's to say, it's an answer that is on the patient's own terms. It addresses their problems, not as in my GP surgery when 20 lights flash up on government targets I've got to hit or not miss with this particular patient, and don't have that ability to fully attend to the patient's own agenda, which is so important, because we know if you do that, then they're less likely to reattend, they're more likely to be healthy and less likely to need drugs and all the rest of it. And then finally, I think what it does is it offers a different vernacular, if you like. It's about improving patients' ability to self-heal. It's about extending nature's own processes of healing, rather than, as we tend to do in conventional medicine, sometimes very successfully with cancer and heart attacks, going in conflict with it, you know, having a cudgel to try and sort the problem. The holistic approach is very much about using the patient's own assets, their own healing systems, and extending them, and has many ripple effects. I mean, we, a few years ago, looked at patients who had various problems, sleeping disorders, arthritis, anxiety, and we offered in this trial, my 11 partners, some believers, some non-believers, some on the fence, patients had the choice of taking preventive therapy for their problem or a herbal complementary therapy. Now, I won't go into any details, but the outcomes of that were that more than half wanted to try the complementary therapy first. And also about 50% were helped by that. Most importantly for this debate, 40% said that next time they had that same problem, they would go off and get the herbal remedy themselves and not necessarily go to GP surgery at all. So enormous economic ripple effects. Finally, post-COVID, COVID, of course, has created an enormous amount of mental health problems, and we're going to need everything we can possibly get out of the box to try and help, particularly young people. And if you look at the College of Medicine website, we're offering everything from self-hypnosis to yoga to Tai Chi, etc. And particularly with post-COVID, which is a bit like ME, where there aren't that many conventional answers. We're going to have to think. We're going to have to think originally. We're going to have to think very much in terms of what that patient particularly wants or is helped by. Population-based medicine is not going to be very helpful in this area, because everyone's different and everyone will have a different thing that's going to help them. So I think in terms of post-COVID, we need to be offering patients choice. We need to be offering something that appeals to them and extends their ability to self-heal. And I think particularly complementary and holistic therapies will be really important. And the future for me is very much us in conventional medicine working very closely with complementary therapists to, as I say, get the best of both worlds.
Thank you, Michael. Karen, if we can ask you now, please.
Hi, so my name is Karen Young and I work for the Federation of Holistic Therapists, the FHT. I'm editor and communications manager there, and I'm also a senior manager. The FHT represents complementary, holistic beauty and sports therapists. We also run an accredited register, which is independently approved by the Professional Standards Authority. I'd just like to say I'm really appreciative of this panel session being organised by yourself, Judith, and also the APPG and the amazing panellists that we've got here today, because I think it's so critical for us to be able to demonstrate the value that therapies can bring to healthcare. Obviously, COVID has presented a huge challenge on every level, particularly health and well-being. And while we know that around 50% of our members have been able to provide virtual support to clients during that time and during lockdowns, etc., you know, there have been very long periods where they haven't been able to provide those treatments that are hands-on, that positive touch. And of course, we know that so many people have been stripped from just day-to-day tactile interventions with even their own family. Who's hugged their mum in the last year? And you know, none of us probably around this table, etc. And so I think it's a real opportunity to demonstrate the positive effects that therapies can have in terms of health and well-being, and it's going to present more opportunities than possibly there have been before. And I appreciate we are talking about holistic therapies here, but I would like to just make the point that for me, holistic therapy is complementary, but it's also beauty therapy and it's also sports therapy, because a lot of treatments are potentially considered traditional beauty treatments, often help people with rehabilitation and to deal with a range of issues that are affecting them emotionally, physically, and mentally as well. So very excited to be having this session. I'm really excited for the panelists to be talking more about the work that they're doing, because they are the people that are working with the population on both in the NHS, in hospitals, within the wider community. And I just think there's this opportunity to tackle this, as Michael's highlighted, a tsunami of people whose stress and anxiety levels have gone through the roof. And all of those are going to be a precursor to long-term conditions if they're not tackled early on. And of course, we know even before COVID that therapies can help people to manage long-term conditions and can keep people out of primary care. It's being able to access that, accessibility and understanding that these therapies and services are available is also key, I think, in going forward. And it's all about preventative healthcare. If we can stop people, I think it was potentially a social prescribing or a college conference, Michael, I heard somebody talking about we need to tackle things upstream. It's no good trying to pull people out of the water downstream when they already have a problem. We need to stop them going in upstream and get that preventative healthcare in place. Thank you. I felt like I talked perhaps a little bit too long.
Thank you very much, Karen. That's really helpful. Next, if we can hear from you, Gwyn, please.
I'd just like to reflect what the previous two speakers have said, and we're really appreciative of the opportunity of this panel session. My role is as education lead for Harrogate and District Foundation Trust NHS Natural Health School, which is quite a mouthful. We are a complementary therapy school. We're wholly owned by the NHS Trust, which I think puts us into a fairly unique position, with all of our tutors actually being NHS Trust employees with NHS terms and conditions. The school, really, it was set up to fulfil two purposes. Firstly, it generates an income so that we can provide free complementary therapies and extra care provision that sits within our health and wellbeing services within the cancer unit. So that fulfills one purpose. But I think the real driving force for setting up a school was, we know that we have many, many fantastic, highly skilled, highly motivated complementary therapists out there. But if you consider that anybody else coming to work within the NHS, within a clinical role, would have experience within the hospital setting before they actually were let loose on patients. And that's with the exclusion of complementary therapies. So we know that many of our complementary therapists, they come out, they graduate with really good foundation qualifications, but they simply don't have any experience of working either with very complex patients or within that healthcare sector, where really we all need to be talking the same language. We need to be able to collaborate and work in a very integrated way with the doctors, the nurses, the physios within that setting. So really that's why the school was set up. We do offer level 3 and foundation qualifications in complementary therapies, but I think our expertise really lies in the specialist programs that we've written that allow qualified complementary therapists to actually come into the hospital and work in a supervised way to gain that expertise. So our programs, they are written around the students gaining competencies that would be required for other healthcare professionals. So we've got competencies that sit within the Care Quality Commission's framework for core competencies. We also look at the National Occupational Standards where they're available, and also the gold standard frameworks for the speciality that they're going to be working in. Because again, we accept that when you qualify as a complementary therapist and you come into the sector, you probably don't have any in-depth knowledge unless you were already a specialist, say, in cancer care. and you were coming from some other clinical background, you probably won't really have a great understanding of what cancer is and what the impacts of that disease and the treatments are for the patients. Latterly, we've written a programme that focuses very much on occupational health. So looking at the NHS at Work network and the work that they're doing and the strategies for including other wellbeing services to support staff at work, particularly post-COVID, we are recognising that there's a real need for us to get support in there for NHS staff and workers. We recognise that many of them have worked very long hours, they've worked in very demanding roles, they have been exposed to high levels of sickness and distress beyond what they would normally be experiencing. And it's our belief as a trust that unless we've got really strong staff, we're not going to have really strong care structures. So we're really keen to sort of build on the work that we do in upskilling therapists to actually work in a very demanding occupational health environment. We also have, of course, the patient services, and we offer quite a number of different modalities for our patients, which was very difficult when we had to stop all non-essential care initially. But we have continued throughout the year to work. We've still offered education using remote platforms, and we've embraced quite a number of different platforms to actually allow patients to self-manage at home with support. So we're quite pleased with the way that we've been able to manage that, but we are accepting now that sort of moving forward, it's a little bit like scooping up a waterfall. It's, you know, it's almost like we've reached that point that mental health problems, anxiety, depression, and the physical effects of having either had COVID or of caring for patients with COVID over a long period of time is sort of like the new pandemic. So kind of that's probably where I am.
Thank you very much, Gwyn, and especially seeing that you're from Harrogate. I didn't realise that. It's nice to hear another Yorkshire accent. Sorry, everybody else. Farah, over to you, please.
Hello, everyone. I'm Farah. I work as a social prescriber in Tower Hamlets in London. I'm also a trained complementary therapist with a background actually in oncology and palliative care. It's been a very interesting experience working in kind of both fields over the pandemic. And what, from a social prescribing point of view, what I've seen, and my colleagues have also seen, there has been this huge increase in mental anxiety, mental health issues, but also physical deterioration because people have not been able to go out, do their usual exercise, have their usual connections. So it's really compounded any existing health conditions that they've already had, or it's actually created some new ones. What I would say in terms of complementary therapies is that those of us who were able to still work, and that was mainly people like physiotherapists, osteopaths, those who are kind of more in the allied health and been accepted as quasi-medical, were given the green light. And unfortunately, there were many complementary therapists who are hugely, hugely talented, have excellent health and safety protocols in place, have always adhered to those measures really as an extension of their patient care, were just unable to work. And yet they had clients reaching out to them and saying, can we see you? My mother would like to see you, you know, even if it was just for something like reflexology. So in terms of just kind of not allowing a huge number of my colleagues not being able to work has had been a detrimental effect, not just only on their clients, but also on the colleagues itself. And I think in that way, how that could have been managed could have been different. You know, I think there was a big sector that should have been still allowed to work with the appropriate PPE. I mean, reflexologists, you know, there's a good distance and all sorts of things that were in place. Many patients are digitally excluded. So while it was very helpful to move things online, you had quite a number who maybe only had one laptop or had one computer. The children need to be homeschooled, or they were needed to work, or there was just a great number in the community who were digitally excluded. And so for them, they could not access a mindfulness session you know, over a laptop or a computer. They weren't able to have any kind of connection. So that also really compounded what was going on for them. In terms of education, I'm actually attached to 8 GP surgeries, and that's great because we have access to the GPs and to the healthcare staff. But I still think there is a broadening of education possibility there in terms of those healthcare providers, so the doctors, the GPs, you know, allied health professionals, of really kind of understanding complementary therapies and how it dovetails, you know, I would say quite neatly actually, in being able to support patients. So there is that ease of the practitioners, but also for those in the healthcare profession themselves to experience complementary therapies. There's a huge number of colleagues who are experiencing PTSD. They've also developed anxiety, low mood, sleeplessness, insomnia, and also for them to be able to facilitate and also be able to use those wellbeing practices and strategies for themselves. So I think there is a real opportunity for education. I think there's a real opportunity to expand that conversation, and you know, the importance of human touch. There is so much good evidence. I think for those who are skeptical, those who are thinking, well, complementary therapies, and I include beauty in that, because beauty is touch, beauty is about rehabilitation, beauty is about connection. It can make you feel good, and when you feel good, you're more likely to feel motivated and move that into other parts of your life. You know, if your hair's done, for example, or someone, you know, if you've just had chemotherapy and someone teaches you how to apply a certain cream or how to look after your face again, because your whole relationship with your body changes, and you kind of think, well, actually, you know, that's given me the motivation and the confidence, and I'm going to try other things. I'm going to go and look after my nutrition. I'm going to try and do exercise and all sorts of things, and actually try and be really good to myself. And that is going to have a really good positive effect on other aspects of my life. And then there's really lots of good evidence. I mean, Tiffany Field, amazing researcher in America. She's done over 100 studies on touch. So she's part of the Miami Touch Institute. It's a medical research, does medical research. So there's lots of evidence there. Professor Banassi at Goldsmiths done huge last year research on touch. It's called the Touch Project. It was even on Radio 4 about touch and how that's really important, and how complementary therapists can really support that. Loneliness, grief, frustration, lots of things that we're seeing that coming out from patients and also colleagues in the healthcare professional. And it's kind of this, you know, people are bumping along or doing their job as well as they can, and at the same time having to govern and negotiate and look after themselves too. So I think there's just, you know, there's some really good work that we can do, and the future is hopeful, especially in terms of supporting long COVID. Complementary therapists, I think, have always been creative in being able to try and make their services affordable, whether that's through multi-bed working, whether that's through doing short treatments. You know, they've also given their services for free. So let's not forget, you know, people who, I've been a volunteer at Guy's, you know, we've given our services for free for a long time, but there needs to be also that recognition that this is an important service and actually put some funding that way. You know, complementary therapies does exist in cancer services, but the budget tends to be quite small compared to everything else. And what does that really say about how we value you? Because if those people don't feel valued, they will stay in the industry for a short time. So when you're looking for that ongoing upskilling in CPD to be able to integrate into a more embedded healthcare system and being able to support like a holistic service, we need to also recognize that these people pay for their training. They often don't get funding for it. So that would be really helpful to, you know, when services are apportioning their budgets, to look at that. And also just looking at also our other colleagues within the complementary health field, things like acupuncture, the NADA protocol, so good. I mean, originally for detox for people who were substance and alcohol abuse, could be in a seated acupuncture group that I used to run. You know, such good results in terms of supporting long COVID, grief, frustration, and, you know, all sorts of things. So if we are looking at a way forward in terms of being able to treat many people as affordably as possible, and for people to be able to take the initiative. So you've got patient responsibility coming back, and that fosters a sense of wellness for themselves and wanting to look after themselves. Then I think there is lots of creative scope for us to be able to do that. And I also teach, and complementary therapies is not going away. And actually during the pandemic, the number of people wanting to enroll on complementary therapy courses like massage and reflexology has actually gone up. So it's not going away, and I don't think complementary is going to go away, but we need to see that support from so many different areas, especially from the government, and in terms of also NICE guidelines. You know, it's already taken acupuncture off in terms of being able to support people with back pain. So we need to kind of look at those things as well. Whether that's been readdressed now, I don't know, but a few years ago, it was removed from the NICE guidelines. So kind of readdress some of those things too. So I think that's it from me. Thank you, everybody.
Thank you very much, Farah. That was really valuable input there. Peter, if we can go next with you, please.
Hi, everyone. Yes, I set up a complementary therapies service back in 2001, and we grew a team of 35 plus therapists. And but key mantras to our work was to obviously provide complementary therapies and choices for our patients, carers and staff, but also to research and disseminate best practice. So we established a training school within our School of Oncology, which continues to work even during pandemic time. So we have had a particular focus on looking at managing symptoms, how to manage things like needle phobia, claustrophobia related to medical procedures, but also managing wounds using essential oils, looking at things like reflexology for anxiety and massage, etc., for patients as well as staff. So the pandemic, well, lots of things were going on at the time. I tried to retire, but I've ended up carrying on with research around fatigue, cough, breathlessness, peripheral neuropathy using different modalities, which we're now in the process of writing up the papers. So I think those have implications for what we're hearing around long COVID. And certainly in the cancer world, we do come across anosmia as a result of chemotherapy, radiotherapy. So there are a number of these symptoms that I think we could contribute to. I was doing therapy work at a hospice, but as other speakers have said, some of us were volunteers trying to reduce the footfall. Some of us were not able to go back into practice, but I have gone back on the nurse register and ended up doing COVID screening. And being a therapist, I couldn't stop myself teaching patients how to do simple techniques on their way in for scans and reassuring carers and doing interventions to help them. And latterly, I've been a vaccination nurse at one of the big centres. And as the population that's coming forward get younger and younger, we're seeing a lot of needle anxiety, a lot of needle phobia. And the FHT very kindly hosted me to do a video for Stress Awareness Month on staying calm and being vaccinated. So I think complementary therapies has a huge amount to offer. I mean, in the rarefied sort of funding situations in cancer care where we have the benefits of charity to support us. And as colleagues have said, many of us have applied for grants, conducted studies. I mean, our team have produced endless papers, and yet still we struggle to get the funding. But we all persevere. I think we're a lot of highly motivated individuals that see what a difference our interventions make to patients. I mean, I say just the other day, seeing someone very frightened to go in for a vaccination, really wanting to be there, teaching her a couple of techniques, and then her coming back to me at the end and said, you've cured my needle phobia. And I'm really looking forward to my second dose and coming back. So, you know, it's a joy to work in this area. It's joy to have the colleagues. And what I've found out is that, you know, we've been really upskilling in terms of using platforms to teach complementary therapies, to teach patients things, using aroma sticks to calm, teaching people simple relaxation techniques over Zoom. there's just fantastic opportunities, and I think we all, when moving forward, will continue to use these platforms, sharing, disseminating best practice. So yeah, it's an interesting time.
Thank you very much, Peter. I'm now going to open the session up for questions from members, and I can see that Peter Dowd's still on here. We've also got someone from Dr. Lisa Cameron's office from the SNP on as well, but I don't know whether Peter is there. Have you got any questions?
Well, I suppose, thanks for everybody in the contributions. They were really sort of helpful, and as someone who's been involved in sort of social care for many years, I recognise the contribution that my professionals can make and that sort of integrated approach. And I think the session was basically looking back at the pandemic, as it says in the note attached to this, over the past year, to learn more about what therapists have been doing. And I think Peter said you were bringing a paper together on your experiences over the past year. I think that it's been written up. Can you, in advance of the sort of publication of that, is there any highlights? Is there anything that you think stands out over and above what you've already said? So you've given your experiences, which were very good, and the other people, other contributors. But what bringing that together? What are the things coming out of your paper, or is it just too early to say?
Is that addressed to me?
Yes.
Yeah.
Yes.
I was talking about papers that we've been doing on patients with symptoms in cancer care settings. So those papers are being written at the moment, but most of that data was collected prior to the pandemic.
Okay.
But certainly we're currently got some work going on at Christie's around teaching staff mindfulness techniques, which we've got some money for to evaluate. So as I say, the process of, unfortunately, of doing research is that inevitably it takes time for these things to come forward. I would like to see certainly a lot of research to be done on long COVID. I mean, obviously I'm coming across people with long COVID in the work that I'm doing, and certainly hearing about fatigue, breathlessness, etc. And I'm aware of teams that are being set up around Manchester to provide interventions and rehabilitation around that. So I'm looking forward to hearing about that. I have been approached to contribute, but we're not actually in that point of setting up a service yet.
Okay, can I ask another question, Judith, if I may? I hope I didn't miss anything from what other people said. I don't think I did. But is there any sort of coordinated approach to this area in terms of research? I mean, you've talked about maybe a couple going on. Is there any pressure for example, the Department of Health to maybe pick this particular issue up? Is there any suggestion that, I don't know, NHS England or one of the state agencies, one of the government agencies, to sort of pick that up and sort of get a grip of it, and sort of move it on a little bit, lessons learned from that, because there are going to be lots of lessons learned from COVID, and it's got to be, some of them have got to be pretty bespoke in that as well, and then incorporate them into a wider lessons learned.
I can see Michael chomping at the bit, wanting to get in on this.
Peter, this is a crucial issue because the health service at the moment spends 0% of its research budget on this area. We were commissioned, the college, 3 or 4 years ago to produce a scoping paper on areas that ought to be looked at by the National Institute for Health Service Research. We produced that scoping paper and looked at the most promising areas, which to begin with were mindfulness and Tai Chi and yoga. Interestingly, we've got to the second stage of research proposals, but none have yet got through. There is an enormous set of antibodies against doing research for this, an enormous hypocrisy, because the complementary therapists are always told that they haven't got sufficient research, but no one's prepared to pay the money to do it. There is some good news. I have to say, Farah, with the National Institute for Clinical Excellence. That is to say, they did ditch manipulation and acupuncture for back pain a few years ago. They're now looking at this awful issue of opiate deaths, which in America now the commonest cause of death in young men, and we are going up with the same speed. And they are looking to recommend acupuncture for pain, and also they say some research for mindfulness. But until someone actually puts some money behind this research, nothing's going to happen. And the other area which I think is incredibly important are some of these herbal remedies, which really could have been helping, I think, during COVID to enhance immune systems, may even have some specific effects, but unproven as yet, for which, again, we have no research. And yet these things have been used for eons, and 60% of our drugs currently come from herbs, and we should be doing research into it.
Can I just follow on, if I may, Judith, if I may? I suppose in the light of COVID, and as I say, the lessons learned that will come from every sector, right from the economy through to education, through to, if you want, traditional and conventional health, environmental issues, a whole panoply of areas that COVID has impacted upon. It's an opportunity in this sense, or would you agree it's an opportunity in the light of COVID to say, given the paucity of research that we've had, given the fact that there appears to be indications that it's been, alternative therapies have been helpful during this period of time, and let's test that out. Do you think there's anything we could do as part of our assessment, part of our study, so to speak, our evidence, our from you? Is there anything you think that we could do to sort of push this? And because you don't know what you don't know, to use that old Donald Rumsfeld concept, isn't it? So would you think this is an opportunity to say, okay, let's draw a line under the paucity of research. Let's use this as an opportunity to sort of tune in to what benefits that might have been brought as a result of these proposals, as a result of COVID, so to speak.
Could I just say, is that potentially an issue going forward though? Because at this point, it might be hard to demonstrate that and to produce the evidence at this stage, just because of the limited interaction that people have been able to have hands-on at this stage. I don't know what other people's views are.
Yes, I mean, we're only just starting to get back with acupuncture at the Christie's, and obviously the symptoms we've been treating there are things like fatigue, and we've done studies. I mean, both Jackie Stringer and myself have done PhD studies in the work that we do. So we've not only got to have the patients through in order to do those studies, but we need, importantly, the money to fund researchers, and all the tests you've got to do. Research isn't cheap.
Yes, and I accept that. I suppose the point I'm trying to make is that you have to start somewhere, don't we? And if the issue is that we haven't had the throughput over the past 12 months because the hands-on, people haven't been able to access as much as they would ordinarily be able to, blah, 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 blah. But this is the point at which do we actually say, in the light of COVID, in the light of our experiences, we know people are using these therapies. Why don't we use that as an opportunity, from here on, to try and test that out, and what we can do as parliamentarians to maybe facilitate or help or get access, whether it be to NICE or whoever, the National Institute, it doesn't really matter. You're in a much better position than I to think, well, most probably this organisation, or might we be able to go to some other organisations who might be able to, fund it in the light of, if you want, potentially the anecdotal experiences of people. So let's draw the line and take it from here and prepare for 12 months hence, when you might have had a body of evidence developed, and then test it out this time next year or this time in 18 months, if that makes sense. So I think it's almost an offer. There might be something we can do, if not to guarantee it, but to help to get it onto that agenda. And if you think that would be helpful, I think we're available. I'm sure you'd agree, Judith, that parliamentarians are available to help try and facilitate that and get you some access to some people who might make decisions.
I was also thinking, whilst you were speaking, Peter, there's also the cost of not having these therapies during COVID. I'm thinking in particular in care homes where you've got people with dementia and other long-term conditions who haven't had access to their normal treatment. I'm sure that there must be some research available on the cost of not having it, as well as the cost of, the cost of not the cost, the social cost of having it, as versus the social cost of not having it. But I think you're absolutely right. I mean, one of the things that struck me as well, if I can kind of just ask a very specific question, which was going back to you, Gwyn, about the school that you've got. How many schools like yours exist? Is it a commonplace thing? Are you the only one?
I think there are other trusts that do have complementary therapy training within various departments, but I think as a standalone business, as part of a business portfolio within the trust, and a complementary therapy school in its own right that's wholly owned by the trust, I think we're fairly unique in that. I don't think that there's anybody else who has that situation. I think from our point in terms of having evidence and having research, we have lots and lots of evidence, lots of data that's been collated that demonstrates benefits for patients who access our health and wellbeing programs and access complementary therapies. And we're quite lucky within the trust to be able to offer quite a wide range of modalities to support patients. I think in terms of gaining research and evidence, I think the first point, I think from my perspective, what comes to mind is it sounds even around the table here today, there have been lots of different experiences of what we've been able to do, what we've been able to offer, what patients have been able to access. We know that complementary therapies is fairly discriminatory in terms of most people only really get to access complementary therapies when they want them, if A, they're dying, or B, they have the money to pay for them. And, I think that's something that we want to address. We certainly don't want to be, in terms of the education and the services we provide for our patients, part of that old term, the postcode lottery. We want really to have a standardization of that. And I think it would be interesting to collate information about what other people have been able to do. And it's a friend of ours within the business once said, never ever let a good crisis go to waste. And I think for all the horrors of the COVID pandemic, we've got to seek the opportunities where we can. And from the data that we've been able to collate, we've actually been able to see that previously we felt that the big benefit of complementary therapies was that we have the time and we have the contact, and that we can offer even very gentle touch where other things may not be appropriate. And I think those things remain incredibly important. But when you actually look at the financial burden on the NHS, efficiency has also got to create some balance with that. And what we found from our experiences is we also offered quite a big service of auricular acupuncture for hot flushes, sweats, hormone deprivation, those kinds of symptoms, vasomotor symptoms that patients were experiencing in relation to their disease or their treatments. And our evaluations found that auricular acupuncture is very, very effective. When the decision was made to reduce footfall and patient safety was absolutely our priority, we decided to stop close contact treatments in accordance with the regulations that were being given. We actually wrote a training program for our complementary therapists to be able to offer the equivalent of auricular acupuncture, but actually using seeds. And then what we did is, when it was safe to actually have patients with us, we actually put the seeds in and then drew an ear map for their bubble at home and provided them with the seeds. And we did consultations by telephone. We used WhatsApp, we used Spotify, we used YouTube channels to do instructional videos on the auricular program, plus other things. And we thought, this isn't going to be the same. It's not the same as having that interaction with our therapists. The patients won't like it. But we actually found that our evaluations, that treatment was as effective for many, many patients as having had the needles in their ears. So going forward, we see that as a huge opportunity for efficiency within the services that we provide, because clearly working that way is much more cost effective than an acupuncturist spending time with single patients. So, you know, it is about sort of seizing the opportunities. And I think, you know, to go back to the research, it's maybe about collating what other people have been able to do during this period of time, and kind of making some sense about what it is that we want to test going forward. Because I think that's one of the problems. We're so far behind with the research that we do have available that the medical profession will accept from us, that it's kind of, where do we start? Where do we, if we have a budget or we have some financial support for research, where do we spend that? Because as we all know, and I think Peter will certainly second me on this, when it comes to research, it's not cheap. It costs a lot of money to actually gain that evidence.
You're on mute, Michael.
Thank you. Michael.
Judith, so I'm afraid I've got to go, but I just want to very quickly add, first of all, yes, research is really important. And I think one case is that we haven't been offering anything other than masks and distancing and everything during COVID. We really should have been able to offer advice on appetite, herbs and things like that. People eat. But one caveat here is that the NHS uses research on the whole to keep things out, not to allow things in. And back paying guidelines were a case in point. That's to say, only 3 primary care trusts nationally had taken them up a year after they'd been produced. So in terms of what you can offer, I think 2 things. One, yes, say we need more research in this area, because it really is unfair to criticize holistic therapies and the same size not to research them. But I think also mobilizing the people here, because the population at large, I think, does have a positive attitude to this. The scientific community and the medical community on the whole has a negative view. The managerial NHS community has a negative view. And therefore, I think we've got to get the people on our side here and say that this is part of choice, part of a democratic system providing health that is around the patients and around the population and going upstream, just as Karen said, and not about the same old biomedical vernacular which was made for acute disease many 100 years ago and which we're still pursuing. And I'm really sorry on that. I've got to go to a meeting at 1 o'clock.
Thank you very much. Thank you very much, Michael. Thank you. I'm sure we'll be in touch again. Thank you. Bye-bye.
Bye.
I think that's really helpful, because there seems to be a consensus around, following on from Peter's point, that there's a reluctance beyond funding to research.
I think it's also, it's understanding. I think it's a wonderful opportunity, and of course we would welcome your support in this, but it's getting an understanding as well. If we're approaching these people, what kind of evidence are they wanting? What are they looking for? Because it takes many different forms. You've got the human story, you've got the patient-reported outcome measures, you've got patient activation measures. It's trying to get an understanding of, they want evidence, what kind of evidence do they want? Because I think that is quite a challenge for the industry. And I will, though, bow to other people who are much more involved in research than I am, and there are others around this table.
We've always tended to...
I think Farah had a hand up as well. Sorry.
Okay, you go first, Peter.
I was just saying that I agree with what Karen was saying. It's important to look at the quality of life, because that's key to this. But we've been doing mixed methods research where we look at particular symptoms. And of course, in long COVID, you could look at breathlessness, you could look at fatigue and then altered taste and smell and things like that, and pain. But we also looked at people's quality of life, and complementary therapies can make an enormous difference to how people cope with those symptoms. When it comes to funding, we've always been dependent on patient interest groups rather than large body funding. So the MS Society funded my PhD, and I know other studies have been funded by patient interest groups. Always been patient interest groups have pushed for more funding and helped us with funding.
I'm just bringing Peter down. I can see him indicating the question.
I think the issue, look, the great thing about being a politician, you actually don't do these things. You get other people to do it for you, and you facilitate things. So I suppose my position, and I can only speak for me, is that how can the point that I think Karen was made, what evidence do they want? I suppose for me, it's the ability to get access to those organizations. So even before you've got the questions, you've actually got to get access to them. And I think from our side, it's not a guarantee that you get access, but it's, if we think it's a potential way forward, we can try to facilitate access to them so that debate thing then can go on, the question and answer session between you and them and you about what they think they need, etc. To some extent, with politicians looking over the shoulder, so you don't then just get brushed aside, or that you have your meetings, so to speak, or meetings, and they say, oh, well, they were a waste of time because X, Y, and Z. It's us being there to potentially facilitate things so you get the hearing that you need, rather than us being able to guarantee anything. We can get you the meetings, we can get you the access. Almost you have to do the legwork in terms of making the case, but we can at least try to get you the access to the people who might make the decisions, and to some extent maybe try and put a pressure on them to take it seriously. Basically, that's the point I'm trying to make.
Yeah, I suppose our role is doing that, and also asking questions. We can definitely ask questions that are pertinent to the industry and to your part in it. You know, we've got a lot of ways to ask those questions. Farah, do you want to come in?
I was going to say, just coming back to Karen's point about what kind of evidence would be suitable, is that one of the issues that you have also, having worked in both voluntary and statutory sectors in the healthcare, is that methods that are brought in to assess patients and whether a particular treatment has been helpful. So there used to be MyCore, and then PAM was introduced, and huge amounts of money has been spent around that. And PAM, which was rolled out, has now been deactivated as of April. So we are no longer using PAM. So nationally, this was rolled out and cost, you know, who knows how many millions probably. And all of a sudden, from the 14th of April, we were told we're not going to use this anymore. And it wasn't the greatest way to measure patients. Whereas something like MyCore worked quite well because you were working on specific perhaps symptoms, but also you were talking about quality of life, which is so important because we know pain is subjective. You know, we know that someone might feel when they're pinched, it'll feel like a 0, and for another person, it might feel like a 10, but you could at least grade it. And I think in terms of like, how do we take that evidence forward for organizations to take it seriously? I think, you know, there's complementary therapists who have been working. It might be useful to get in touch and try and pull some of those things, but also we're going to be left with a very sick nation. And this is going to be long-term sickness. And while we talk about one of the things about herd immunity, but the herd is sick. The herd is sick. And if that is not pressing enough for people to kind of go, I might not have the evidence, but actually there is a body of evidence there, because Gwyn's School, Peter's School, so many amazing organisations therapists who work in complementary therapies and worked with NHS go and do their CPD, and they do their own ongoing developmental work and have also evidence and case studies of patients they've worked with. If we're not utilising that and not bringing them into the conversation, we have lost so much. And also, let's look at this globally, because COVID did not affect just the UK. So I'm sure there's pockets of international research that are happening also, you know, with institutes, with lots of other well-being, wellness centres, integrated medical centres that are both straddling both sides, that we should actually be saying to our colleagues, saying, look, let's have a conversation about this. What have you found? And let's try and gather that around, because we have a sick herd. And unfortunately, what I see as a social prescriber is that people are feeling quite demotivated, and it's very difficult even to get your initial GP appointment. And you know, some of the symptoms are so sort of like, it's like malaise, it's fatigue. Could it be, you know, I'm going through menopause? Could it be menopause? Could it just be I'm anxious, I've been at home too long? There's so many things that are overlapping that we really need to kind of look at this and kind of go, okay, for the next generation, there's going to be a huge impact too. And so we should be looking at this in quite a serious way, even if we don't have the full evidence that we need. It has to start somewhere, because the herd is sick and will continue to get sicker if we don't try and utilize things quite creatively, quite rapidly. You know, this is not about having another conversation for another 3 months, because we'll hit into another sort of like third wave, flu season will start. So it's cyclical, it will continue. So, you know, the interventions, even if it starts small, you know, whether it's research in London or Manchester or Ireland, wherever, I think there is scope to kind of mobilise colleagues.
Can I just put in there that one of the concerns that we have as an organisation is that, you know, we feel that potentially that there's a call here for some development of the infrastructure for complementary therapies. One of the things that I particularly find interesting is that complementary therapists, as of last September, anybody gaining a qualification needs to undergo a module and an assessment in infection control. Now, I would question why it's actually taken a pandemic, a coronavirus pandemic, for us to actually recognise that that's something that complementary therapists should have from the get-go. It's one of the issues when we bring students in as postgraduates to actually do some complex needs training or some specialised training within the trust. It's something that we're starting with from scratch very often with therapists. So I think sometimes we've got to sort of go back a step and actually look at what infrastructure we have in terms of the training. I think there've been leaps and bounds in terms of foundation training for complementary therapists, you know, over recent years, but I still think there's work to do with that. And going forward, I think we're all recognising that, yes, the herd is sick. I agree completely. We can see that this is really potentially a disaster waiting to happen. I think certainly in terms of the healthcare workers being able to continue, that's a huge concern for many, many trusts. Yes, we see that there are complementary therapists can actually fill this needs gap. You know, I think we've got great, skilled, highly motivated therapists with great skill sets who can help here, but what do we do then to support those therapists? Because many of the complementary therapists who are now going to be working with patients going forward, with clients going forward, are going to be dealing with much sicker, much more weary clients and patients with problems that they haven't seen before. So, you know, I think, again, it goes back to the infrastructure and, you know, what do we have available and how do we fund services to support complementary therapists to be able to effectively fill that gap. The big thing at the moment for the NHS is the Nhs Self-Management Models. And we know that this has been seen as the next big thing that's going to save the NHS. We know that we need more patients to be able to make choices and self-manage, to be able to make the purse strings stretch to care for the nation. But equally, we know that when people are already really sick, that's the time that they don't have the energy to actually take that step to self-care. So, you know, again, it's like closing the stable door when the horse is gone. Really, complementary therapy should be sitting within a budget for public health. You know, we should sort of be learning from this and saying, shouldn't our complementary therapists actually be trained at a before you're sick level and then enabled to develop to work with people when they are very sick? Because at the moment, I think usually people can only gain complementary therapies through the NHS and similar healthcare providers. you know, if literally you're dying, if you're very, very sick, if you've got cancer, if you're palliative, if you've got a long-term condition that can't be cured, then usually there will be patient funds to support you to have complementary therapies. But other than that, we've got this very two-tier system. So I think, yeah, it's really important that we address that complementary therapists have a huge role to play in terms of self-management models. Absolutely, we know that we're very good at that, but we've got to get in there early enough and stop being the people that patients are sent to when there's absolutely nothing else or nothing else works.
Yeah, well, thank you for that. I'm afraid that time is not on our side this afternoon, and we're supposed to be finishing at 1:15, and so with 1 minute to go, I will say thank you very much, everybody. That was such an interesting discussion that we had there. We completely went off script, which I think is always a good sign of an interesting and lively discussion. I'm sure that you'll agree with me that we've discussed some very important points there, and it's been very informative, and I hope that we take this forward in a constructive manner so that we could actually make a difference in this, because I think you're speaking to the converted in terms of parliamentarians on this call, that we all agree that complementary therapy needs to sit side by side rather than outside. So thank you very much. I'm sure that we'll be back in touch to discuss further, and I'm sure that we'll be very, very happy to have further conversations with all our panellists. Peter, Peter Dowd, that is, do you want to say anything before we end?
No, Judith, that's fine. Thanks, everybody. It was really, really very helpful. Thanks.
Thank you. Take care. Thank you. Bye-bye.
Bye.
Thank you, everybody. Thanks.
Thank you.